pain, and she believes he has been taking more pills than usual lately for abdominal pain. An arterial blood gas is drawn showing a pH of 7.28, a PCO2 of 40. Electrolytes are sodium 134, potassium 3.5, chloride 94, and bicarb 12. What is the acid-base disorder? So there are some very helpful clues in the question stem for this case. The patient is diabetic with polyuria, polydipsia, and abdominal pain. So all that paints a picture of DKA. And in diabetic ketoacidosis, we expect an anion gap metabolic acidosis. Also, they tell us that this man's been using narcotics, and narcotics can cause respiratory depression and create a respiratory acidosis. So just based on the question stem, we are already concerned that maybe we're going to have an anion gap metabolic acidosis complicated by a secondary respiratory acidosis. So let's go through the numbers. The pH is 7.28, which is low, so we have an acidosis. The bicarb is 12, which is low, so we have a metabolic acidosis. And then the PCO2 is 40, which is normal. So right away something is wrong. We'll use Winner's formula to check this PCO2 in a minute, but I can already tell you it's not going to meet our expectations because it is normal. You should always have a low PCO2 in the setting of a metabolic acidosis. This man does not have respiratory compensation, so something is wrong. And then finally, we do the anion gap anytime we see a metabolic acidosis. And for this patient, it's 134 minus 94 minus 12, which is 28. So that's high, meaning we have an anion gap metabolic acidosis. So we'll use Winner's formula to check the PCO2, and we find that the expected PCO2 is 26. I've shown the math for that down here if you want to review it. So our PCO2 is higher than expected at 40, so there is a concomitant respiratory acidosis. And remember, you can use Winner's formula to prove this to yourself, but already you know that a normal PCO2 in the setting of an acidosis is a problem. It should never be normal. So we have an anion gap metabolic acidosis combined with a respiratory acidosis. The anion gap acidosis is coming from DKA, and the respiratory acidosis is coming from hypoventilation, most likely related to respiratory depression from the narcotics that this patient has been taking. Last case is a 60-year-old woman who presents to the emergency room with massive vomiting for 3 days. On exam, she's hypotensive and tachycardic. Skin turgor is diminished. An arterial blood gas is drawn showing a pH of 7.24 and a PCO2 of 24. Electrolytes are sodium of 140, potassium of 3.2, chloride of 79, and bicarb of 10. What is the acid-base disorder? So once again, we've got to look carefully at that question stem. She's been vomiting, so we expect a non-anion gap metabolic alkalosis. She also is dehydrated. Anytime you see a severely dehydrated person, especially someone who may be in shock, you have to wonder if there's going to also be a lactic acidosis, which would give an anion gap metabolic acidosis. So let's look at the numbers. The pH is 7.24, so there is an acidosis. The bicarbonate level is low, so there's a metabolic acidosis. The PCO2 is also low at 24, so there's respiratory compensation. Because they're abnormal in the same direction, a mixed metabolic and respiratory disorder is less likely. The anion gap is 140 minus 79 minus 10, which is 51, which is very high, so we have an anion gap metabolic acidosis. So we can use Winner's formula to determine the expected PCO2, and I've shown the math for that over here. The expected PCO2 is 23 plus or minus 2. Now our actual PCO2 is 24, so this tells us that we have normal respiratory compensation and we do not have a concomitant respiratory acid-base problem. Now this is an anion gap metabolic acidosis, so anytime you have an anion gap metabolic acidosis, you need to rule out that you don't have a second metabolic acid-base problem, and you do that using the delta-delta ratio. So the delta anion gap for this patient is 51. It's the patient's anion gap minus a normal gap of 12, and that's 39. The delta bicarb for this patient is a normal bicarb of 24 minus the patient's bicarb of 10, and that's 14. So the delta-delta ratio is 39 over 14, which is 2.8, and that is high. And we discussed this in the other modules on acid-base disorders, but when you have a delta-delta ratio greater than 2, it means you have a concurrent metabolic alkalosis, which is what this patient has from vomiting. So this is an anion gap metabolic acidosis from lactic acidosis with a concomitant metabolic alkalosis from vomiting, and this is actually a very common clinical scenario that you can see in the hospital. So let me finish up with a summary of what we've seen in this module. We saw a case of diarrhea with a simple non-anion gap metabolic acidosis. That's a very basic acid-base problem that you should be able to solve. We saw an acute respiratory acidosis, and you should recognize that the CO2 goes up in acute respiratory problems, giving you an acidosis. We saw renal tubular acidosis, and remember that in these problems the urine anion gap is very helpful, and you should recognize question stems for RTA patients with things like kidney stones and autoimmune diseases. We saw chronic respiratory acidosis in a COPD, a very classic clinical scenario where COPDers retain carbon dioxide and walk around with a very high level of bicarb from renal compensation. We saw metabolic alkalosis of unknown cause, and we've reminded everyone that you want to know the volume status and the urinary chloride in those situations to determine the etiology. We saw methanol toxicity, which remember gives you an anion gap metabolic acidosis with vision problems. And then finally, we did two mixed disorders. The first was an anion gap metabolic acidosis with a concomitant respiratory acidosis. And in these situations, Winner's formula doesn't match, and that's how you can recognize them. And then the last question was a patient with a metabolic acidosis and a metabolic alkalosis, and this is where the delta-delta was abnormal. So these are 8 pretty standard bread and butter type of acid-base problems. If you had trouble with them, go back to the modules on basics of acid-base physiology and then watch this module again and make sure you understand how to solve all the problems. And that concludes our module on acid-base problems.